Yeah, did you want to maybe back here? Is that okay?
Yeah, just because it's blocking the...
Yeah, okay. How about that?
You okay?
It'll
I'd say it wouldn't look aesthetically pleasing, but then again, this is
all right. We got our technical problems taken care of. So thanks for that. So thank you all for coming out tonight for our seminar. I was joking with one of the guests that they made it through the snowdrifts okay here in February. So we were lucky we had good weather for this. Just to let you know a couple things. Most people here have been to conferences before. We ask you to not take phone calls or make phone calls in this room. You go to the hallway to do that, and to make sure that your electronic devices are on vibrate or turned off.
Refreshments are available in the lobby.
Yeah, refreshments are available in the lobby. And next month, March 6th, we have Dr. Arash Tavani, who is a neurologist here at GBMC, who'll be talking about headaches, which is going to be, I think, a very interesting talk. And then the next month, April 3rd, these are all the first Tuesday of the month, Dr. James Mercy, who many of you have heard before talk about osteoporosis, is going to talk about diabetes. He's the chief of endocrinology here at GBMC and a very good speaker. So in thinking about today's talk on GERD, or reflux, however you want to describe it, it brought back some memories to me because I'm old enough so that I remember the days before that we had even Tagamet or cimetidine, which many of you probably don't know about, but ranitidine or Zantac you probably do know about because it's available over the counter. But even before that, we used to treat reflux and ulcer disease with bland diets and 7 doses of antacids a day. And I don't know if any of my patients ever took 7 doses of antacids a day and survived to talk about it. But that's all we had at the time. And we did talk a lot about lifestyle stuff. There was some talk about that. It was mostly medication. So a lot has transpired in the last 25 years or so with respect to the technology in terms of diagnosing this condition, treatment, and so forth. I did decided I would do what a lot of people do, doctors and patients. I went on the internet to find out what I could about what the internet is thinking about reflux. And I especially looked at some of the home remedies that are touted by some as being helpful. And maybe some of those might be endorsed or debunked by Dr. Johnny later, I don't know. But anyway, but in terms of what I found out, it made up of a good door prize for today. This is whoever wins this is going to have the GERD emergency kit. This is right next to your defibrillator at home. And it has some interesting items in it, you know. I didn't know this, but chewing almonds supposedly helps with GERD. So we have some almonds.
Oh, really?
Yeah. Now you know with GERD, no coffee or the caffeine, that sort of thing. But you can drink herbal tea, not the kind that has citrus in it. But this is chamomile, which is very soothing. Apple cider vinegar cures everything. GERD, so we have some of that. Oatmeal and raisins. So I got combined oatmeal and raisins. Okay. Licorice, supposed to be good, probably not this kind, but this is symbolic. And real licorice. And cinnamon, which many of you know also is good for
So that's where
your
it
blood
went.
sugar. That's where the cinnamon went to, right. Now, in terms of medications, I brought our old friend antacids. Still very useful. You take 7 doses a day if you want to. And also brought some ranitidine, which is the older medication that we used to use a lot. And of course, the purple stuff, okay. We all know the Ravens should have been in the Super Bowl, but that's okay. This is actually Prilosec, which you get over the counter, but it's another type of acid lowering medication. So you've got a lot of things in here that could be helpful. I couldn't find aloe vera juice, which is also supposed to be good for GERD. That's a little bit hard to come by, but you can also get an aloe vera plant. You just break the plant off and suck on that, and that's good for you. So it's also good for burn. So that is the
Hey, could I borrow one of those?
for today. No, you cannot borrow those. All right. So moving on, it's my pleasure to introduce Dr. Neeraj Jani, who has been here at GBMC for a couple of years now. He is the chief of the Digestive Disease Division here at GBMC, which is gastroenterology, basically. He went to medical school in Rochester, trained at the residency at Mount Sinai Hospital, New York, which is trial by fire, I'm sure, and then did a fellowship at Pittsburgh. And he's going to be talking to us about GERD and related issues. Dr. John?
Thank you. Thank you, Dr. Green.
Is it right?
The light.
Yeah. I think it's going in the back. Probably just turn that around.
Should go like this or better?
Is that all right?
Is that better?
All right.
Work on my hand. Quite great. All right, well, thank you all for spending your evening with us. And I was flattered when Dr. Green asked me last month to come and talk about one of the topics that's dear to my heart. So as I trained in Pittsburgh, I did my gastroenterology training there. I then spent a extra year doing advanced, what's called interventional GI. And a big part of my training, because we were part of really what's, I think, the Midwest, is a huge amount of Barrett's esophagus. And we'll talk a little bit about Barrett's esophagus. So obviously, you know, most of you have heard about what we call acid reflux or gastroesophageal reflux disease, GERD. But are many of you familiar with Barrett's esophagus? Some of you have heard of it? Okay. So really, you know, I think there's two aspects to reflux disease. There's the aspect of obviously it's uncomfortable, the symptoms, and everything it produces. But from a second side of this that I worry about is Barrett's esophagus and esophageal cancer. There's been some great improvements over the last 5 years in the diagnosis of Barrett's disease, and I'll touch on some of these things today, and then treatment of Barrett's disease, which is non-surgical. And it's really been a shift in sort of how we were doing things compared to even 10 years ago. So if you have any questions, feel free to ask. Some of this may be a little more technical, and I'll try to sort of go quickly through that part of it. Okay, so gastroesophageal reflux disease is defined as symptoms or mucosal damage produced by the abnormal reflux of gastric contents into the esophagus. It affects about 20% of the population, and it frequently produces symptoms that progressively will lead to some damage of the esophageal tissue. It is the costliest GI disorder that we deal with, costing up to about $10 billion annually. The diagram on the right shows the basic anatomy of reflux. So what you see is the esophagus. You see this muscle at the bottom of the esophagus, which is called the lower esophageal sphincter, and then you see the stomach. Now, to some extent, we always have a small amount of reflux, but it's this dramatic amount of reflux over time that really leads to symptoms as well as mucosal injury and damage. So the typical symptoms, and this is what I always find interesting, is that it's very variable. Some people will say I have heartburn, some people will say I have indigestion, some people will say I have bloating or I have burning in my chest. But there's really the whole host of sort of atypical symptoms which clues me in to reflux. And these can include anything from hoarseness to frequent throat clearing, you know, which we call laryngeoesophageal reflux, to even exacerbations of asthma, aspiration, pneumonias, poor dentition, chronic cough, and something we call globus sensation, which is the sensation that something is stuck in the back of my throat. This can progressively lead to difficulty swallowing, feel that food is getting caught, and then progressive problems. Now, what are some of the risk factors for reflux? Well, the biggest thing is that that lower esophageal sphincter relaxes more than it should. So normally that muscle should relax when there's a food bolus in the esophagus. It senses it, it says, okay, I need to relax and open up to let the food go into the stomach. But we have these multiple relaxations, we call them transient lower esophageal relaxations, which then allow reflux to occur. Obviously, a weak lower esophageal sphincter will cause the same problem. Poor peristalsis. So peristalsis is how your gut contracts. So if you have an esophagus that's not contracting like it should, or a stomach that's not contracting like it should, you may have reflux. The the job of the esophagus is only one thing, to take food from your mouth into your stomach. And when the sort of traffic is not moving in the right way, it leads to reflux. Obviously, on the other side is the stomach. So if the stomach is not moving like it needs to, then you see a lot of reflux. And you see reflux of not just acid, but also of that yellow-green substance we call bile, which can be quite caustic to the esophagus. And then in conditions where you have